Hello, Imad.
Hello, sir. How are you?
I'm good. How about you? Um, can I test my slides? Is that okay?
Yes, sir. I can hear you,
Can I test my slides?
but I cannot see your video.
Oh, really? I can see myself.
Yeah, but I cannot see you. Yeah, now I
Why
can
is
see you.
okay? Can I share screen to test my slides, my
Yes, now
presentation?
I can see you.
Okay. Can you see my slides? My screen?
I can see your presentation, sir.
Wonderful. Okay. Yeah, wonderful. Let's just play one video and see if plays or not. Let me find a video. Yeah, it's playing. Okay, wonderful. I'll stop sharing the screen. Okay. Okay, let's wait 10 more minutes. Okay. Oh, Yuri Bandeira. Yuri tá aí, o Clemar tá aí. Oh, o Yamaki também. Valeu. Carolina. Can you guys hear me? Just Imad.
Yes, sir, we can hear you.
Okay, wonderful. So, oh, I can see Carol is here. Well, so probably you will,
Oh, no.
yeah, Carolina, probably you have to introduce me, right?
Oh,
And
yes.
then, okay. And probably I'm gonna talk just about MCA aneurysms today. It's gonna be, um, if I include glioma, insular glioma, it's gonna be a very long talk. So I think it's better to go deep into one topic at a time instead of having 2 or 3 topics.
I
If
do
you
agree. I do
Okay,
agree.
wonderful. So let's wait. And today
5 minutes.
I have many colleagues from Hospital das Clínicas here. And also I
Yeah.
have Aurora Borealis.
Very good. Good indeed.
Oh yeah.
Hello, everyone. We are getting messages at chat already, Wen.
Yes.
Good to see everyone. I'm already recognizing many of the names. It's very nice to have you all back for this Friday.
See my glasses. I don't see any cat. Where are your cats?
I don't know. I just arrived, so
Oh,
they
okay.
are probably sleeping, right?
Oh, there's one cat. She's always willing to
It's
participate
true,
in the webinar.
true. And whenever I'm studying, she's always with me. She's going to be a neurosurgeon.
Okay, wonderful.
Imad, nice to see you. Thanks. I haven't said hello when I come in.
Yeah,
I was in a hurry.
No
I'm
problem.
sorry. Good to see you again,
Same
virtually.
here.
Okay, let's wait.
Yeah, 2 more minutes, and then we will be all right to start.
Okay, wonderful. I think, 11 a.m. in São Paulo is probably is a good time for at least for IMAD.
Mm-hmm.
It's they are 8 hours ahead. So must be 7 p.m. It's late, but not that late. Probably still not good for Asia, Japan,
Right.
China. It's not good. But for South America, Europe, it's okay.
Mm-hmm. Yeah, it's like we said, it's always a compromise, right?
Hmm.
Welcome, Dr. Wang. Nice to see you. Welcome joining us.
Hmm.
There we go. This is our time. Should we win?
Yes,
Everything okay at your end?
yes, I'm
Okay.
ready.
So, welcome everyone to one more World Federation Rhoton Society, International Rhoton Society Anatomy Day. And this is the brain chapter, the subcommittee on anatomy. And today we are very glad to have Dr. Wen. He's going to talk about the Sylvian fissure and its application in MCA aneurysms. We are starting, as you see, we are starting to migrate from the surfaces of the brain to the vessels that supply them. So we have a nice talk with Wen. Welcome, Wen.
Hello, everyone. Good morning, good afternoon, good evening, all over the world. Can I share my screen now?
Yes, you can.
Okay, I'll just go ahead and now share my screen. So just a quick reminder. Can you see my screen? Can you guys see my screen now? Okay, wonderful. Just a
We
quick
do.
reminder. So every last Friday of the month until 2025, we're gonna have World Federation Neurological Society's Rhoton Anatomy Day. Every last Friday, it's gonna be about the brain. Every first Friday of the month, it's gonna be about the peripheral nerves. And every second Friday about the month, second Friday of the month, it's gonna be about skull base. So today is my turn. So I'm gonna talk about the microsurgical and angiographical anatomy of the Sylvian fissure and its influence on MCA aneurysm surgery strategy. Young neurosurgeons, they will always asking me, why do I have to study anatomy? And is vascular neurosurgery dying? I'll try to show you that by the contrary, exactly the opposite. World need microneurosurgeons. We are less and less microneurosurgeons nowadays. Okay, and why to study anatomy? Because it's our firm belief that to have a solid foundation for successful microneurosurgery, you're gonna need this. First, you have to know the anatomy. Why? Because you have to study anatomy to be capable to understand the information provided by the imaging, like angiography, like MRI. and try to correlate it with anatomy. Second thing, you have put together what you saw on the imaging, think about anatomy, and you have to be capable of planning the surgical strategy based on the information from the anatomy and the radiology. And then you have to bring them together, bringing the anatomy, imaging, surgical planning into the surgery. Obviously, you need to have a fine surgical skill through extensive training. Probably the best way to get a very good surgical skill is always performing surgeries. And obviously, you need very good anesthesiologist and also very adequate instruments. Okay, let me see. Okay, let's talk about aneurysms. When we are dealing with aneurysm, what we want as a surgeon, I want to go and reach the aneurysm as quick as possible to establish the proximal control over the apparent artery. This is a principle number one of the vascular neurosurgery. Also, I want to avoid the fundus, the dome of the aneurysm. I don't want premature rupture of the aneurysm before I get in there. So we need to know the exact location of the aneurysm intraoperatively. Just a quick example why we're studying anatomy today. 64-year-old female, day 6 of the intracerebral hemorrhage. She presented aphasia and right hemiparesis, strength grade 3. So we can see here, there's a hematoma over the left Sylvian fissure. And here we have this CTA showing the aneurysm of the MCA over this area. This is a 3D rendering reconstruction of that CTA. So what does it tell me? So this is AP view. A stands for anterior, AP view. Apparently, there is an aneurysm arising very close to arising at the genu of MCA, pointing anteriorly. This is a L stands for left. So lateral view, left side. The aneurysm is like a sausage. It's pointing anteriorly and pointing a little bit downward. Okay, located at the genu of the MCA, the left MCA. So the question is, this is a exposure, terional, left cranial craniotomy. This is a Sylvian fissure. This is a temporal lobe, frontal lobe. The tricky question is, where is the aneurysm? Should I split Sylvian fissure from here? The aneurysm should be here, 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 there, where? When I was young, when I started doing aneurysm surgery, I was very afraid every situation to split the Sylvian fissure. Should I split superficially first? Should I go deep first inside the Sylvian fissure? But I was very afraid to find the aneurysm. You know, surprise aneurysms here, you have caused premature rupture. So let me tell you this. What gyrus is this one? Just to get started. This is what? This is pars orbitalis. Well, this is pars triangularis. So if I know where the tip of pars triangularis is, I know where's the genu of MCA. Where's the genu of MCA? Using your X-ray vision, genu of MCA is just a little bit proximal to the tip of the pars triangularis. So genu of MCA is over here in this area. But the aneurysm is pointing anteriorly, a little bit downwards. Pointing anteriorly, aneurysms like this one, the red one. Aneurysm can be pointing anteriorly, superiorly, posteriorly, inferiorly. or inferiorly or anteriorly. In this case, it's more anteriorly and a little bit inferiorly. So in surgery, it's going to be aneurysm will be pointing upwards and a little bit anteriorly. So once again, where's the aneurysm? Where's the dome? Where's the direction of the dome of aneurysm? So pars triangularis over here. Genu of MCA is over here. It's more like 8 millimeters proximal to the pars triangularis. Pointing upwards. Point upwards is pointing towards us. Pointing a little bit downwards means pointing towards the temporal lobe. So the aneurysm is pointing over this area. Okay, so if I go and split all the way the superficial part of the Sylvian fissure, I'm gonna probably cause premature rupture of the aneurysm if I'm not out. I don't know about this anatomical details. The dome of aneurysm will be here waiting for you. So what will be the best strategy for this case? Split over here, go deep instead of going superficially first. You go deep and try to get the proximal control, or you go more anteriorly, more proximally, split the Sylvian fissure over here to get the proximal control. So this is the importance of what we are going to talk. You know, during my career, I still have many, many questions, and I'll ask all of them to you and try to make you think today, and together we can find the answer for all those questions. So this is a Professor Yasargil's golden rule. You know, during the examination, angiography, patients looking like this, but during the surgery, the patient is like this. So anything's pointing anteriorly, in surgery, will be pointing superiorly. Okay, so this is a 3D rendering reconstruction. So the aneurysm actually in the surgery will be like this. Will be pointing here. Okay, now you know why. Other thing that we have to pay attention is the shape, morphology, the curves of the M1. Why? To get the proximal control. But if M1 is curved like this one, like this one, if the M1 is curved posteriorly, you will be much easier to find proximal control under the aneurysm. But if M1 is curving superiorly, it's best to find the proximal control proximal to the aneurysm. The problem is the aneurysm is located between you and the proximal control. How can you solve this? Okay, we'll come back to this case. You will see the video of this case. I just gave you many questions. You see the shape of M1 here. It will be much more difficult to get the proximal control under the aneurysm than to come from here. The problem is the aneurysm is between you and the proximal control. How you solve this? So the answer for those questions would be anatomy. So let's see. So you have that case. So what would be your recommendations for your chief resident who's going to operate on that case? Good luck. You know, go split all the way superficially. We already told that, mentioned that. In that case, go deep first. Don't go superficially in the Sylvian fissure. So let's study other cases, other situations. We will have to change our strategy according to the anatomy of the aneurysm. So another example. This is a carotid artery. This is MCA left. Okay. So here is the genu of the MCA. This is carotid bifurcation. So this aneurysm is pointing down. Lateral view, aneurysm pointing down. AP view, aneurysm pointing down. What would be the recommendation for your chief resident? Okay. It's the same recommendation you're gonna give to this case. This is the right side, carotid artery, carotid bifurcation, M1, very short M1, aneurysm pointing anteriorly. Is the recommendation for this case different from the previous one? What do you think? If you don't know, start thinking, because I didn't know many years ago. Probably now I know, and I want to let you know what I know, so you don't have to make the same mistakes I made in the past. This the recommendation you will see. Be careful even during the craniotomy when you're trying to drill out the sphenoid wing. You might rupture the aneurysm. We're gonna see soon why. And for this case, don't pull. This aneurysm is attached to the temporal lobe, temporal tip, or pole of the temporal lobe, or the horizontal portion of planum polare. Okay, don't pull, retract the temporal lobe. You go and dissect the Sylvian fissure from the frontal side. Okay, we're gonna see all this. I have some experience in MCA aneurysm surgeries over the years, and I want to let you know, give you the lessons that I've learned over the years. Temporal lobe present four surfaces. One is medial, one is superior, one is lateral, one is basal. We are talking today about the superior surface of the temporal lobe that will constitute part of the Sylvian fissure. Okay. Sylvian fissure itself. Okay. This is a frontal view of the brain. Okay. Sylvian fissure occupies two surfaces. One is over the basal surface, and one is over the lateral surface. So this is like just similar to a letter L. One is over the lateral surface, one is over the basal surface. And we will see that what are the components of the Sylvian fissure. Just like a sandwich. In the bottom, there's going to be the temporal lobe. So it's very crucial, very important that we study the different morphologies of the temporal lobe, the upper surface of the temporal lobe. You can see clearly here, there one area different from this one and different from this one, okay? And the limit is what? This is the rhinal incisura. So from the rhinal incisura, posteriorly, it's gonna be the medial temporal lobe, okay? And on the top of the sandwich, there's gonna be what? On the basal surface, we're gonna see, I forgot the name. This is rectus gyrus. This is a rectus gyrus. This is the olfactory tract. I forgot the name of this structure. Do you know? Do you remember? This is the medial orbital gyrus. And how about this one? This is the posterior orbital gyrus. What is the name? And how about this one? Lateral orbital gyrus. What is the name of this area formed by the lateral aspect of the posterior orbital gyrus and by the posterior aspect of the lateral orbital gyrus? Give me the name. This is a very famous. This is a pars orbitalis. Okay, so pars orbitalis is actually made of two gyri. One is lateral and one is posterior orbital gyrus. Okay, and how about this area? It's formed by the posterior part of the medial orbital gyrus and by the medial part of the posterior orbital gyrus. Posterior medial orbital lobule. Is it important? I will show you soon. This is very important. Okay, and then we have the insular pole. Around the insular pole, the MCA will turn from the basal surface to the lateral surface. So this is going to be where the Genu is located. So Genu of MCA is telling me where the insular pole is. And it's telling me the transition between the basal and the lateral surface. And also, at the medial wall of the lateral surface of Sylvian fissure, there's going to be insula. This is a right insula with the central sulcus. We're going to study about this later, okay? And this is the anterior surface of the insula, which is the posterior wall of the M1. We're going to see this soon. Posterior wall of M1. We're going to see this soon, okay? Okay, and also the Sylvian fissure will be located on the lateral surface. This is tip of the pars triangularis. So we're gonna have many take-home messages. You know, the first one will be Sylvian fissure occupies two surfaces. One is on the basal and one is on the lateral. Okay, and Sylvian fissure present a superficial part and a deep part. So let's study first the superficial part. The superficial part is like it's like here. So we don't see anything if you don't split the Sylvian fissure, right? So just by looking at this, what is located on the top, on the front, closing the basal surface of the Sylvian fissure? This is called Sylvian fissure stem, okay? So it's on the front and on top, it's going to be the posterior orbital gyrus and lateral orbital gyrus. On the bottom, it's going to be the tip of the temporal lobe we call. This is very important, okay? If we see the temporal lobe upper surface, the most posterior part is composed of planum temporale. It's constituted by the middle and the posterior transverse temporal gyri. Transverse because directions is transverse. The most famous one is the Hash's gyrus, which is the anterior transverse temporal gyrus. So one morphology, posterior planum temporale. Another one is the Hash's gyrus, and another one is this Grand Canyon here. Huge canyon. It's called the planum polare. But planum polare presents two parts. One is the vertical part, and one is horizontal. Horizontal parts we also call as the temporal pole or the tip of a temporal lobe. This vertical part is very important. Why? Any aneurysm arising from the genu of MCA pointing laterally is going to be attached to the vertical wall of the planum polare, just like the first case I showed you. Okay, let's go. So superficial part of a Sylvian fissure on the basal surface. This is a brain from autopsy. We can see the arachnoid membrane here, binding, connecting what? Connect the posterior orbital gyrus to the horizontal portion of the planum polare. This arachnoid presents a name. It is called the frontotemporal arachnoid reflection. This is a very difficult part. This is the part that we split during the, when we split Sylvian fissure during surgery, very often it is very stuck to each other. But also it can serve as a landmark. For instance, you have a cavernoma over the posterior orbital gyrus. What landmark should you follow? The arachnoid membrane, okay? Okay. So we can see that superficial parts like this, okay? Covering the anterior and mainly the superior part of the basal surface of Sylvian fissure, we're gonna have this. If we divide the M1 from the bifurcation, if we divide the M1 from the bifurcation to the genu into two halves, the proximal half, proximal M1 is facing, what is the roof of the proximal M1? Anterior perforated substance. What is the anterior wall, upper anterior wall? The posterior portion of the posterior medial orbital lobule. If we divide the distal M1, what's located behind? Behind is going to be insular pole. In front It's gonna be what? The posterior orbital gyrus and also the pars orbitalis. On top, it's gonna be what? Insula, anterior surface of X. We're gonna review this, we have to memorize this by heart. If you don't know this, you'll be in trouble. So how is, the frontotemporal arachnoid reflection in the surgery? It's like this. This is a tip of a pars triangularis. So this is already on the basal surface. Frontal lobe, temporal lobe. This is the arachnoid that we split during our, surgery. So this is a frontotemporal arachnoid reflection. My question, what part of the brain is this? What gyrus is this one? This is the lateral orbital gyrus. This is what? Pars orbitalis. Okay, this is what? More deeper, more proximal. This is a posterior orbital gyrus. And how about here? What part of the brain is this one? This is the vertical wall, vertical part of the planum polare. And how about this? Going almost under the sphenoid bone. This is the tip of a temporal lobe, or the horizontal part of the temporal lobe. Okay, so we can see and we know where we are. So if we continue to follow the frontotemporal arachnoidal membrane deep, we're gonna find this, the optic nerve. And what is this? This is olfactory tract. So every time I ask my chief resident, go to the carotid cistern and release CSF. He will ask me, Dr. Wen, can you give me a good landmark to find the carotid cistern? I'll tell him, go, if you see a white structure, which is olfactory tract, you follow posteriorly, you're gonna find the carotid cistern. Why? You see here, you find the olfactory tract, go back, you will find the carotid cistern. Okay, release CSF. So in the aneurysm acute stage, ruptured aneurysm is very important. Usually brain is swollen and is angry, so you have to release CSF. Okay, let's remove the superficial part and see what's going on in the back, in the deep part. If this is, the tip of temporal lobe has been retracted downwards, so we can see here, this is a deep part of the basal surface of the Sylvian fissure. If we remove the M1, the carotid artery, all the arteries over here, you see this carotid bifurcation. This is A1, this is M1. Okay, let's go and remove all this and see what neurostructures are located behind it. So we can see this. We can see this. Okay. So this is the insular pole. And this is what? I can see red dots, blue dots, like an elevation over here. What is this? This is called anterior perforated substance. So the red dot is the lenticule striated arteries. The blue dot are veins, are inferior striated veins. They will form together with the deep cerebral Sylvian vein to form the first segment of the basal vein. Okay, so you can see the shadow over here. To the medial part of the insular pole, limit between the anterior substance and the insula. So what is this edge? This edge is very famous. Do you know the name of this edge? This is called limen insula. Limen means limit, threshold. Limit between what? Between the carotid cistern and the Sylvian cistern, because M1 arises from the carotid artery inside the carotid cistern. Once M1 crosses this limit, it will enter the Sylvian cistern. Okay, so this is a famous limen insula. And also we can see upwards, this is the limit of the interperforated substance. So what is the inter limits of the carotid bifurcation? You can see this is the posterior medial orbital lobule, And also over here is going to be the lesser wing of sphenoid bone. This is very important, okay? The lateral medial limits, posterior medial limits is optic tract. Posterior lateral limit is the uncus, okay? Anterior is the semilunar gyrus of the uncus. Well, let's go. So if I go ahead and remove the posterior of the gyrus and the lateral of the gyrus, we're gonna see we're gonna have a very good view of the anterior surface of the insula. So the first short gyrus of the insula, this is accessory gyrus. This is a transverse gyrus. We're gonna study about insula when we the next occasion when I will talk about insular gliomas, anatomy for insular gliomas. Okay, and this is the anterior surface of an insula. And this is MRI. We can see that this is a posterior orbital gyrus. So this is the anterior surface of the insula. So this is anterior limiting sulcus of the insula. This is insular apex. And this is that part that we try to dissect in the surgery, but it's very stuck, usually very stuck. And where is the frontotemporal arachnoidal reflection? Where? It's over here. So if we split the neurosurgery here, I have still to split between the opercula of the orbital gyri and the temporal lobe to finally get into the deep portion of the Sylvian fissure over here. And you can tell this is what? This is bone. Okay. Do you see? Oh, sorry. This is bone, right? This is the coronal suture. This is bone. This is sphenoid wing. Aneurysm arising from here, pointing anteriorly, will be very close to the bone, to the dura. So be careful when biting off the sphenoid bone during craniotomy or when you're opening the dura if the aneurysm is pointing anteriorly. We're gonna talk about this later. Okay, this is the exposure that we get. Okay. Let's talk about this later. This is just to show you the location of anterior limiting sulcus of insula. Anterior limiting sulcus of insula. Guess what? Anterior limiting sulcus of insula is continuous with the anterior. You see, do you remember the rami that constitute the pars triangularis? The anterior and the horizontal ramus of the anterior horizontal and ascending ramus of the Sylvian fissure. So the anterior limiting sulcus of insula is here, is continuous with the anterior horizontal ramus of the Sylvian fissure. Okay, we have many superficial landmarks to guide us. So forget about this slide, but this is the most important of my talk. You see, this is a tip of the pars triangularis. See, it's pointing just a few, like 8 millimeters behind the genu of MCA. So if your aneurysm is arising over here, pointing anteriorly, it will be attached to that vertical wall of the planum polare. So how to find it? You see where the pars triangularis is over here. You know that aneurysm is just a little in front for any aneurysm arising from the genu of MCA. So let's go to the lateral surface. Just like on the basal surface, lateral surface will present superficial part and a deep part. What are the superficial parts? It's this one. Anterior horizontal, anterior ascending, and posterior ramus of the Sylvian fissure. On the basal surface, the superficial part, you remember, is called the stem of the Sylvian fissure. On the lateral surface, anterior horizontal, anterior ascending, limiting what? Pars triangularis, and the posterior ramus going posteriorly. Okay, and then pars triangularis, opercularis, precentral, postcentral, supramarginal. We're gonna talk about this later. And as the medial wall of the deep portion of the Sylvian fissure on the lateral surface is going to be insula. Very important, the relationship between each part of the insula versus each part of the, just like here, precentral, postcentral. What part of the temporal lobe is related to the postcentral, for instance? Hassus gyrus. What part of the temporal lobe is related to the precentral and the pars opercularis, the vertical wall of the planum polare? Okay, this anterior part of the insula is covered by the pars opercularis and the triangularis. The posterior part of the insula is covered by the pre and post central gyri. This is absolutely very important. So let's keep removing. If I remove the supramarginal gyrus, we're gonna see a very good view of this part, planum temporale. Okay, but if I remove the postcentral gyrus, I'm gonna see very well number 2. This is Hassus gyrus, and also part of the posterior portion of the insula. If we remove the precentral gyrus, we can tell that the precentral and the postcentral gyrus, they will cover the posterior half of the lateral insula. Number 3 is pars opercularis. Number 2 is triangularis. They will cover the anterior half of the insula. Let's say your patient has a glioma over the posterior half of the insula. Where should you start splitting the Sylvian fissure? You will check where's the postcentral central gyrus, where's the precentral gyrus, because the tumor is over that area. Okay, your patient has a glioma occupying the anterior half of the insula. It's located, it's covered by the pars opercularis and triangularis. So this is very important. Okay. If we remove pars opercularis, pars triangularis, we're gonna see the vertical portion of planum polare. This is a wonderful dissection made by Professor Vicente Quiles Quesada from Valencia, Spain. And then if you completely split the Sylvian fissure, it will look like this. You have here the anterior surface, which is triangular shaped area with its apex over here, Genu of the MCAs over here. If we turn to the lateral surface, we're gonna see all these branches, first short gyrus, second, third, central sulcus vas insula. We're gonna talk about this in another webinar. Today we're gonna deal with the aneurysms. When I was young, this angiography has no meaning to me. So if I point, this is what? This is carotid, I know. This is A1, M1, Genu, everybody knows. But my question is, why is this, the meaning of those loops? For instance, this one, the artery will loop horizontally, rather straight to reach the bone and then exit, okay? Why is this one running like this, downwards and then exiting here? Where's this loop located? Okay, so if I told you this is called the point M, Sylvian point. It's located at the most posterior and medial aspect of Hassus gyrus. Okay, because you guys probably are too young. In the old days when I was resident, all we had as a diagnostic tool for the brain is angiography. Okay, even for trauma. So this, if you notice, this Sylvian point is located in the center of this square. You see, anterocerebral, the top of the head, lateral aspect of the head, and the bottom will be the M1A1. So Sylvian point has to be located right in the center. If there's a hematoma over here, it will compress the brain or expand, and the Sylvian point will be located downwards. So if you see, instead of here, Sylvian point is over here, there's something going on, some hematoma, whatever, superior to the Sylvian point. Okay, Sylvian points, instead of in the center, it is located here. There must be something thalamic, some hematoma over here, dislocating laterally the Sylvian point. Okay, the same thing. If there's something over here over the temporal lobe, it will elevate the Sylvian point. So instead of being here, it will be here. So, but now we are talking about MCA aneurysm, right? Okay, so where is the aneurysm? What structure is related or attached to? Okay, because I don't want to cause premature rupture. Is it important to watch the morphology, the shape, the curves of the M1? Obviously, yes. So let's see. So where's the aneurysm in my surgery? So what is the best strategy to clip it? Okay. This is how, in a rupture aneurysm case, how the brain looks like when there's no hemorrhage. This is a normal brain. So this is a regular left craniotomy. Okay. So my question is, you already know where the genu of the MCA is, right? So my question is, what part of brain, what gyre is this one? This is lateral surface. Down there, basal surface. So what is the first gyrus on the lateral surface of the brain over the Sylvian fissure in this area? This is what? This is pars orbitalis. And then you can see clearly this is a pars, the tip of pars. This orbitalis, this is triangularis. Okay, so the tip of pars triangularis is here. So my question is, where's the genu of MCA? Genu of MCA is just few millimeters proximal to it. So obviously deep in this area, but deep. So I have pars triangularis. I know where the genu is. Okay, so let's do some exercises. This is just the same anatomy. Okay, tip of a pars triangularis. It's over here, and the genu is just few millimeters ahead, deep, proximal. Okay, this is a very important landmark. So take-home message number 2, pars triangularis is just distal to the genu of MCA. Let's do some exercises. My question, this is MCA, right? This is a temporal lobe, right? Is there any temporal lobe over here? Inside the square formed by the anterocerebral, A1, M1, M2, Sylvian point, this square. Is there any temporal lobe? Of course. Here, parahippocampal gyrus, hippocampus, mesotemporal lobe are located inside this square. Is there any basal ganglia thalamus located here? Yes, obviously, it's located here. Insula is medial to M2. So, temporal lobe, the mesotemporal lobe is located inside the square as well. Okay, you can see here. This dissection made me understand much better. Okay, okay. And also another golden rule that we have to remember is that in the patient in surgeries like this, during the angiographies like this, anything pointing up in surgery, pointing posteriorly. So always 90 degrees backwards. Okay, let's say. So we're talking about MCA aneurysm, right? So this is the genu. Where's pars triangularis in this angiography? It's here. As soon as find, it's here. Few millimeters proximal to pars triangularis, it's gonna be the genu of MCA. So this is the first loop after the genu. Where is this loop located? It's telling me what? It's telling me that here is the anterior limiting sulcus of insula. Okay? It's telling me what here? This is the most medial posterior part of the Hash's gyrus, pointing towards the atrium of the lateral ventricle, pointing toward the pulvinar of the thalamus. This loop is telling me what? This loop is located in the flat area. What flat area do you have back here? Planum temporale, okay? Which one is most, this is anterior, is looping downwards. It's in this area, planum polare, vertical portion, okay? So each curve, you see this loop. Is this loop, why is this loop why does it doesn't achieve go all the way to here? See, this loop goes all the way to the bone. This way does not. Why? Because our brain is not like, it's not like a ball. Our brain's like a, you know, an American football, the ball, like a olive. So it's skinnier in front, skinnier behind. It's not a round ball. So anything projecting up on angiography is posterior, and posteriorly, occipital is skinnier than the parietal. So where is the largest width of our brain? So over this area. So what gyrus is this? This is the supramarginal gyrus. So little detail can tell you a lot on the angiography. So let's go back to MCA. From the bifurcation, carotid bifurcation, we call M1. From the bifurcation to the genu. Okay, if we divide the M1 into two halves, one is proximal half, one is distal half. Okay, proximal, distal, and then genu. Aneurysm rising from the proximal half, pointing up. What's your recommendation for your chief resident? The aneurysm pointing up, it will be related to these arteries. What arteries are these? Lenticular striate arteries. So be careful. Don't retract the frontal lobe. Dissect the Sylvian fissure from the temporal lobe, temporal side, because the aneurysm will be attached to this interperipheral substance. Be careful with the arteries. Okay? Distal half pointing up. What do you think? Do we have a lenticular striate artery over here? No, you don't see anything because there's not anything. This is anterior surface of insula. Okay. Let's see. Carotid bifurcation, genu. Proximal half, distal half. Proximal half pointing up, anterior peripheral substance. Distal half pointing up, anterior surface of insula. Okay. Proximal half pointing up, anterior peripheral substance. Distal half pointing up, insula. This is insula. This is insula. Take-home message. Pointing up, M1 segment. Pointing up, proximal half, anterior peripheral substance. Distal half, anterior surface of the insula. So don't pull, don't dissect the Sylvian fissure from the front side. Go to the temporal side. Okay. Example. Genu, proximal half, distal half. I would say this is more or less midway between the proximal half and distal half, but still be careful with the lenticular striate arteries. Okay. This is a lateral view. This is a frontal view. So where's the aneurysm? So if we go in the beginning of the surgery, release CSF from the carotid system, I know where the carotid is. If I know where the pars triangularis is, I know where the aneurysm is. I know that in this case, it is more or less midway between half distance between the carotid and the pars triangularis. Let's see here. The tricky question is this: where is the aneurysm? Pars triangularis, you see? The genu will be here. Carotid artery will be here. The first step of surgery will be releasing the CSF from the carotid system. So carotid will be here, deep. Pars triangularis over here. The aneurysm will be halfway, but deep on the basal surface of the brain. Okay. So let's see. Carotid, the M1. This is aneurysm attached to the insula, anterior surface of the insula. Be careful when you clip, there's always a bifurcation, a branch, okay? Okay, M1, carotid bifurcation, Genu is over here. M1, proximal half, distal half. Aneurysm pointing down from the proximal half. What's your recommendation for your chief resident? It is attached to where? To here. You can see, if you don't know, see here. What is this? This is uncus. So aneurysm arising from the proximal half pointing down, it is attached to the uncus. So what is the recommendation? Dissect the Sylvian fissure, dissect the carotid system, but don't touch the lateral part of the carotid artery because it might be attached to where? To the uncus. So you can split, you can release yourself from carotid cistern, but don't go laterally because an aneurysm will be there. And also split the Sylvian fissure on the frontal side of the M1. Okay? Okay. Distal half pointing down. If you don't know, look at here. This is the horizontal portion of the plenum polare, or the tip of the temporal lobe. So, in a nutshell, aneurysm arising from M1 pointing down is attached to the temporal lobe. Okay, so don't pull the temporal lobe, don't retract until you get the proximal control first. So this is, see, this is right now incisura, uncus. So proximal M1 pointing down is over here. Distal M1 pointing down is over here. Okay. Take home message. M1 segment pointing down. M1 proximal half, uncus. Distal half, temporal pole. I showed this case before. Genu, carotid artery. This is, for me, this is like a pointing down a little bit in the distal part of the proximal M1, okay? But now we know it is pointing towards the temporal lobe. So on the basal surface of the brain. So this is the pars triangularis. This is carotid artery, halfway between the pars triangularis, carotid artery will be here. So this is much more closer to the carotid artery. So let's see. Carotid artery is over here. Tip of the pars triangularis over here. Genu of MCA is over here. Midway, the aneurysm will be over here, but deep on the basal surface, pointing toward the temporal lobe. So this, you don't have even to split a lot of Sylvian fissure. This is an unruptured case. Optic nerve, left side, carotid artery. This is vein. This is the loop of the M1. This is aneurysm pointing towards the part of the temporal lobe that is located under the bone, the lesser wing sphenoid. What part of that is that? That is the temporal pole, or the horizontal part of the plenum polare. Flipping, always check, because there's always a bifurcation. In this case, hidden by the aneurysm, but always have to check. Okay, another case. A little bit of hydrocephalus, blood inside the atrium, inside the temporal horn on the left side. Okay, the patient bled inside the ventricle. And then this is CTA, reconstruction. We have this vasospasm. We have the, this is a carotid artery, A1, M1, pars triangularis, Genu. This is proximal M1. This is a distal M1. Proximal M1 pointing down. Proximal M1 pointing down. The patient also has a PCOM aneurysm. Okay. Proximal M1 pointing down. Where's the aneurysm? Uncus. Okay. So this is tip of a pars triangularis. Genu of MCA is over here. Carotid artery is over here. The aneurysm is just next lateral to the carotid artery, but deep, attached to the uncus. Okay. So I'm pretty safe on the surface until we reach close to the carotid artery. In this case, we chose not to go to the carotid artery first, but go from the Sylvian fissure towards, you see this is optic nerve, this is carotid artery, this is where the aneurysm is located. This is uncus, okay? Every time you see the mass, something like this is where it ruptured, you see? So I can see the neck, but can I clip it? Yes, you can put a pilot clip and then, but you have to always check because there will be always a bifurcation. So I have to go and check quickly. But now I'm not afraid that aneurysm will rupture because it's been clipped. But I can see here, you can see the branch, the temporal branch over here that has been included in the pilot clip. So I have to readjust and then put it back again, but sparing the arteries, okay? So it's very important for you know beforehand where the aneurysm is located. Then you clip the PCOM aneurysm. It's okay. So this is the picture, intraoperative picture. Carotid arteries over here. This is optic nerve left. This is the interclydite process. This is uncus. Okay, and the temporal branch is running over here, but here is hidden by the clot. Okay. M1, aneurysm pointing laterally. It's not up, it's not down, it's not anterior, it's not posterior, but following the axis of the Sylvian fissure on the basal surface. For instance, like this, aneurysm pointing laterally. Aneurysm pointing laterally means it follows the same axis of the Sylvian fissure on the basal surface. So what? So let's see here. This case, left side AP view, a very early bifurcation. I consider M1 from the bifurcation of carotid artery to the Genu. Okay, so Genu is over here. This bifurcation is before the Genu. Okay, so where's the pars triangularis? It's over here. So this is somewhat midway between the pars triangularis and the carotid bifurcation. It's on the basal surface. Then aneurysm is more or less, it's not along the way, the axis, but there are two lobulations over here, one anterior, one posteriorly. One anteriorly means what? One posteriorly means what? Let's see. So this is what? Pars triangularis, carotid artery will be here, Genu will be here. That aneurysm is just a little bit proximal to the Genu. So let's go again. Tip of pars triangularis. This is Genu. The aneurysm should be over here, deep in the basal surface of the brain. So let's go quickly. Splitting, just normally we do, the way we do normally. This is what? When splitting what? The frontotemporal arachnoid reflection, okay? And then in the deep part, we can see the aneurysm over here. You see the aneurysm here? One part is pointing toward the frontal side, and one other part, this small one, is pointing toward the temporal side, that larger bulging towards the frontal side. Okay? What part of brain I'm removing this? Where's the proximal control? How can I get to the M1? Can you see M1 from here? I can see the only distal branch. I don't see. It's very difficult for me to cross above the aneurysm to get to the proximal control. See, I want the proximal control, but I can see only those two branches and the aneurysm blocking my view. So what to do? I have to get the proximal control from below the aneurysm. And for this, I have to release the lobulation that attachment of the aneurysm to the orbital gyrus over here. So now I'm doing this. Now I'm getting the M1 from below, okay? And see what happened. Now I have freed. The aneurysm is freed. See the small lobulation over here. The larger one is over here. This is a distal inferior trunk. This is a superior trunk. And whenever I try to clip the small lobulation, the clip will slip, will not hold in place. So what to do now? This is M1, proximal control. Temporary clipping, quickly apply the clip. You have to know beforehand the size of the clip, the size of the aneurysm. Okay, remove. And after removing, you have changed the shape of the aneurysm. So now aneurysm will accept the clip. The small lobulation will be clipped. So tip of pars triangularis, Genu of MCA, proximal to the Genu. Aneurysm pointing anteriorly, anywhere from here, distal or proximal or distal pointing anteriorly. What will be your recommendation? Good luck is not enough. Be careful from the start. Be careful when you're biting off the bone, because over here, aneurysm pointing anteriorly might be attached to the dura that is attached to the bone. So be careful by biting off the lesser wing sphenoid. Be careful of opening the dura. You might rupture the aneurysm. Okay, so here anteriorly, it will be if it's pointing anteriorly and up, will be related to what part of the brain is located. It sits on top of this area, the clinoid process, anterior clinoid process, lateral to the olfactory tract. Do you remember? Medial to the olfactory tract is going to be rectus gyrus. Lateral to the olfactory tract is going to be medial orbital gyrus. In this area, what gyrus will be located here? The posterior medial orbital lobule, formed by the posterior part of the medial orbital gyrus and by the medial part of the posterior orbital gyrus. So aneurysm at this level, pointing anteriorly a little bit up, will be attached to the posterior medial orbital lobule. From here, aneurysm, distal M1, aneurysm pointing anteriorly, careful. It will be pointing towards the Sylvian Fissure stem. So aneurysm rising from here, you cannot, at least it's not advisable, it's not wise to split all the way the superficial part of the frontotemporal arachnoid reflection, the superficial part of Sylvian Fissure. You might rupture the dome of aneurysm. Okay. M1 pointing anteriorly. Proximal half or distal half. It depends. It might be attached to the Sylvian Fissure stem, the frontotemporal arachnoid reflection. If the aneurysm is bigger, can be attached to the dura and to be attached to the lesser wing sphenoid. Or if it is pointing down, it can be attached also to the temporal lobe. Okay, this case, pointing anteriorly, pars triangularis over here, Genu is over here, carotid bifurcation. This is very close to the carotid bifurcation, pointing anteriorly. So I'm already aware, be careful, the aneurysm is pointing anteriorly. In surgeries, it will be pointing up towards the surgeon. So tip of pars triangularis, Genu of MCA. The aneurysm is over here pointing up. So I should not dissect Sylvian Fissure all the way from here. I have to dissect a little bit until I reach the Genu, and then I have to go down, go deep to catch the M1 for a proximal control. So it depends on the case. You should not split all the way superficially the Sylvian Fissure. So this is, you see, this is M1 Superior trunk, inferior trunk. Aneurysm is attached to where? To superficial Sylvian vein over here. Very dangerous if I start splitting superficially instead of going deep first. So that's why you have to know the anatomy. That's why you have to know the angiography, because it changes your strategy. Your strategy will be much safer. Aneurysm M1 pointing backwards. Proximal M1 backwards is what? Uncus. Distal M1 pointing backwards is what? Insular pole. Arising now from Genu. Now we are not talking about M1 anymore. From the Genu. The tendency is the aneurysm, will follow the direction of the flow. Usually for this case, for instance, could be like this, could be like this, pointing laterally. If it is pointing laterally, it will hit what? The vertical portion of the planum polare. It will hit here. Vertical portion, you see? Vertical portion of the planum polare. If you see here, this is an aneurysm arising from the genu pointing laterally. Will be attached to this part. Which is this part? This is the vertical part of planum polare. Let's see this case. Left side arising from the genu pointing laterally. I already know this will be attached to the vertical wall of the planum polare. Okay. Pars triangularis, genu, arising from genu, will be attached here. This is the case, unruptured, left side, pars triangularis, genu, arising from genu, pointing laterally, will be hidden by this part, which is the vertical portion of the planum polare. Let's see quickly. So I start dissecting normally, open in the frontal temporoarachnoidal reflection. See, we already see the aneurysm over here. So it is hidden, you see? It's hidden by this part of the brain. What part of the brain is vertical wall of planum polare? So I'm applying the spatula. Oh, this is the aneurysm. And this is the clipping, okay? But normally you should not do this because I have dissected the fundus, the aneurysm away from the brain. You should leave it. Don't do this. I'm doing because this is unruptured. So at the genu pointing laterally, it will always be attached to the vertical portion of planum polare. Okay, 69 years old, unruptured intracranial aneurysm. This is straight M1, almost at the level, it's at the level of the genu, okay? So what do you expect? It will be attached to the vertical part of planum polare, right? So, but check this out. This is what? This is the floor of anterior fossa. What is the floor of anterior fossa? This is planus sphenoidalum, okay? Anteroclinal process over here. This MCA is way above the planum, the floor of anterior fossa. So instead of being attached to the vertical wall of the planum polare, it will be attached to where? This is the right side, frontal, temporal. This is attached to the frontal lobe instead of vertical wall of planum polare. So we have to pay attention to every detail that image is offering to us. Okay, another case, aneurysm arising at the genu, pointing laterally. So where it should be attached to? Will be attached to the vertical wall, vertical part of planum polare. Okay, but you see, this is acute stage. Where's the tip of pars triangularis? You can calculate. It's always more or less 2 to 2.5 centimeters from the transition between the basal and the lateral surface. You count 2.5 centimeters will be around here, even though sometimes there's nothing similar to a triangular shaped gyrus, but it's always here. So if the aneurysm, if the pars triangularis is here, Genu is over here. The aneurysm should be here. So don't retract. You go dissect the Sylvian fissure frontally on the frontal side of the MCA. Don't go lateral to the temporal side, and don't retract the temporal lobe over here. Okay, so let's see. So I'm splitting here. I placed spatula, and then we can see here the distal branches, and here M1 aneurysms attached to the vertical wall portion of the plenum polare. Okay, now I'm removing the clot to see better. One distal branch is over here. Another distal branch is underneath the. This is aneurysm. This is the front. This is superior trunk. Superior trunk. This is inferior trunk. This is the neck of aneurysm. I kept the dome attached to the vertical part of the plenum polare. Okay, see the location? Now I'm checking the inferior trunk, and then you apply the clip, okay, without detaching or pushing or retracting the vertical wall of the plenum polare, okay? Okay, one more. You must be a little bit tired, but I want to show you this. Sylvian fissure hematoma, 43-year-old female, third day post subarachnoid hemorrhage, aphasia, and Glasgow Coma Scale 14. So this is the aneurysm on the left side. Apparent for me, to me, it's pointing laterally, so along the axis, okay, a little bit proximal to the genu. So it is located at the distal part of the distal M1 for me, pointing laterally, posteriorly, and down. So for me, pointing down means in surgery will be pointing anteriorly. Pointing anteriorly a little bit laterally, okay? Left side. So this is pars triangularis. Genu, aneurysm should be over here, but it is deep. At least I was thinking this way, deep. So this is acute stage. So first we go to the carotid artery, carotid cistern to release SF. And then I was sure that the aneurysm is deep in the Sylvian fissure on the basal surface. And then I thought it was, at the beginning, it was a small branch. And I was at the surface of a Sylvian fissure. So I was not understanding, actually, until now, I don't understand what happened. Because for me, the CTA was telling one thing, but in surgery, the reality showed me this the otherwise. So now we are in this stage, bleeding. So for young neurosurgeons, the only way you have to do is increase the suction power with the aid of another larger suction tube. Try to find a hole and try to control. This is not enough for a carotid. For instance, carotid aneurysm, the blood flow is much higher. For MCA 1, 5 French suction tube, if you make it right on the top of the hole, you can control the bleeding. Okay, now I know where the hole is, more or less the hole is. I have to quickly dissect and think quick. Why did I rupture the aneurysm if I was on the surface of the Sylvian fissure? At least I thought I was on the surface of the fissure, because probably the aneurysm was pointing anteriorly. But the CTA didn't tell me that. So I have to dissect quickly because I was clipping something else must be included inside the clip, establish the proximal control. I did the surgery more than 10 years ago, and then try to quickly find the distal branches and try to follow the distal branches in the middle. There's a mass, the clot, to see where the aneurysm is. and where the bifurcation is. So this is where the clip was. The aneurysm was actually pointing up in this case. That's why I ruptured. So I was lucky, got clipped, but careful interpretation is very important. That was 10 years ago. Okay. Now it was last month, 64-year-old female, day 6 of the intracerebral hemorrhage. She also was aphasic and right hemiparesis strength grade 3. So left Sylvian Fissure hematoma. Aneurysm here. Okay. CTA pointing entered. This is the first case I showed in the beginning of my presentation. Aneurysm rising from the genu. I hope now you have a different idea from when I started my talk. Okay, aneurysm rising from genu. Pars triangularis over here. This is a few millimeters proximal to the pars triangularis. Pointing anteriorly means what? Anteriorly a little bit downwards. Anteriorly means on the genu, at the genu, it is pointing towards the vertical portion, vertical wall of the planum polari. So be careful. I was aware, okay? Tip of pars triangularis, genu must be over here. So the aneurysm must be over here. And how about the proximal control? Proximal control, the M1 is kind of straight. I have to see the situation. The problem is aneurysm will be blocking my way, my view to the proximal control. Maybe I have to go under it, okay? I don't know. Let's see it in the surgery. This is how I thought that aneurysm would look like in surgery. Will be like this, pointing up, hidden by the vertical wall of planum polari. So let's go. You see, the M1 is curving. So might be a little bit difficult for me to get to the proximal control under the aneurysm. But I think it's equally difficult to get the proximal control from the front because the aneurysm is like a sausage. It's a high. It's big. Okay, this is the video. Pars triangularis. It's over here. So I bet the aneurysm will be over here. Maybe I can get a room here to get the proximal control. But anyway, I have to dissect, go deep, try to avoid the superficial part because I might rupture aneurysm sac. Okay, I was doing this surgery with my chief resident, Dr. Robert. So we are splitting at the level of tip of pars triangularis, but the clot was very hard. Most of the clot was not suckable. You have to coagulate, cut, very troublesome, okay? And then I'm trying to find distal branches of MCA in the middle of the clot, a hard clot. So sometimes clot will come out, and most of times, no. You have to coagulate, cut. Finally, I find a distal branch. It looks to me are the distal branch from superior trunk. And now I'm approaching the area of where the aneurysm is, supposedly is. I can see, I've tried to follow the distal branches of the superior trunk, I thought. And you can see something similar to that resembles a bifurcation. Now, this is a technique with Professor Sugita. You dissect the veins so you can retract. Now we are somewhere close to a bifurcation. Do you see this? I will show you later. Very important. Do you see this? Aneurysm is like this. So every time you see something whitish, it's not brain, but something whitish like a cotton. Be careful because this is a fund of an aneurysm where it bled. Okay. So now I finally found something similar to bifurcation. This is the inferior trunk, superior trunk. This is a neck and shown with bipolar, the neck. And then you can, I'm pointing at the dome. This is where the aneurysm ruptured. Don't touch this. I was showing that we can clip this way or that way. And then my chief resident chose to clip this way and he's done a great job. See, this is the dome of aneurysm. Don't touch this. I made this mistake in the past. I thought it was a cotton or something. And okay, finally, at least I thought it was worthwhile. I was in Gainesville as research fellow 30 years ago and studied anatomy. And then I came back to Brazil doing many surgeries, many questions. And then every time I had a question inside the OR, I go back to the lab, try to dissect. This is Miss Mary. Carolina must remember. And this cycle, lab, surgery, questions, lab again, back to the surgery, questions, back to the lab. So we've been, many people will ask, oh, there's very few opportunities for me to dissect, for me to be fellow somewhere. We're working on that. We are part of a organization called the International Rhoton Society. Our job is to find, to expose, to give opportunity, to disseminate knowledge among the young generation of neurosurgeons. One of our goals is to find a place to build a lab, so everybody can have the same opportunity that I had, that Carolina had, and that many other Dr. Rhoton's fellows had in the past to study anatomy. But in São Paulo, we are trying to build that. It's going to be reality in probably 1 or 2 years in São Paulo. We're going to build something like what he had in Gainesville at the University of Florida. But meanwhile, we're always running courses. So you can dissect, the brain, just like, what I showed you. You have some questions in surgery, go to the lab, dissect, try to solve those questions. Coming November in Taipei, Taiwan, we'll be running the practical course, 5-day course there. It's a great opportunity to dissect and then later to attend the meeting of the 4th International Rhoton Society meeting, where the not only ex-fellows, students of Dr. Rhoton, but everybody who enjoys anatomy, appreciates anatomy will be there. Okay, also in São Paulo, we are for young generation neurosurgeons. When I was young, I didn't have money, even to come back home to get married. So I got married by proxy. I was in the United States. My wife was in São Paulo because I didn't have money to fly back to get married. So in São Paulo, we have this course as well at the University of São Paulo. And dissect the same course. We dissect the brain and then we try to answer questions. This is going to be a 5-day course. The investment is approximately $600, which is less than 1/3 of the other courses that we run in the rest of the world, in China, Taiwan, United States, in Portugal. And then, so if you want to enjoy summer in Brazil, December, this is the place to go. We will run this course twice a year, one in the first semester, second in the second semester. The link is, this one will be the same. If you can attend this one, in the future, you can always attend for a very cheap price. And I would like to thank, I'm here very nicely talking, giving you talks, but I cannot do this alone. And I would like to thank our team, Carolina is right there, and they're all experts in their areas in neurosurgery, and they will helping you as instructor in our practical course. And please buy this book, sell your car, buy this book. This is not that expensive, just joking. Buy some good instruments, okay? Read this, and you have time. There are many papers published by Dr. Rhoton's lab. I could publish this paper about Sylvian Fissure. I think it's going to be useful for you. And another paper in Japan, but it's written in English about the pars strangularis and as a landmark for the MCA aneurysms. And last 4 editions of Humans Neurological Surgery, we had opportunity to write a chapter 2 about surgical anatomy of the brain. But the most important thing is, before he died, Dr. Evandro gave me permission to include in this chapters 33 videos of his best surgeries. He handpicked those 33 videos. Maybe it's worthwhile to check it out. Okay. So you don't want to know the anatomy of the brain, but you want to know about transcavernous approach to the basilar bifurcation aneurysm. Go there. This is video 65. Okay, far lateral approach, pike aneurysm, video 66. And finally, I would like to thank all of you, with the patience, paying attention to my talk. And all I want is you learn what I spent 30 years to learn, So you guys, younger generation neurosurgeons, will start from here, where I am, and will not make the same mistake I made in the past. But you will carry all the lessons I learned in my career. Okay, this is the spirit of the International Rhoton Society, and we are trying to disseminate through the cooperation of the World Federation of Neurological Societies. I thank you so much for your attention. Thank you very much.
Hey, Wen, can you all hear me? I don't know if my audio is working.
I can hear you very well. Not now.
What's going on?
I'm hearing again. Maybe.
I think
It's okay now. Yeah. Say again.
I'm testing again my microphone. Let's see
yes,
if
now I can hear you.
Okay.
Go ahead.
I knew we were in for a treat, right? Such a nice talk, Wen. Thank you so much. I think we have a few questions, and I think we have time for it. If anyone wants to jump and put some more questions in the chat, I will start with a question from someone you know, Dr. Grade. He was with you in Portugal. You met him in the summer course in Braga. And he's asking, in which specific case do you go directly subfrontal to the carotid cyst and instead of opening the Sylvian fissure distally first?
And we did many cases like this. You can clip, for instance, PCOM aneurysm in 5 minutes. But I work in an academic institution. One day you will have to face the case that you have to have hands, skills, knowledge to dissect Sylvian fissure. If you don't do this, when you need it, you won't have the skill. You will not be able to do this. So my philosophy, at the academic, even at the private practice, is always do the most, the comfort. I'll not say, you might ask me, you can ask me, you might ask me, if I spend 5 minutes, why should I spend 15 minutes? But if you split the Sylvian fissure, you don't have to retract that much. I use retractor only at the stage of clipping the aneurysm, so I keep both hands free. If you don't split Sylvian fissure, you have to pull against, resistance of the brain. But definitely you can, as long as you know how to split Sylvian fissure, you can clip aneurysm in 5 minutes. I have no question about it. But the opposite, in other situation, if you need to dissect a very tough acute stage Sylvian fissure, but you are not capable of, then the patient's in trouble.
Great. There are a lot of people saying thank you and how much informative and motivative your talk was. And I don't think we do have any other questions, but what you mentioned, I was thinking here that we are truly doing a spiral curriculum on the brain committee, because we keep coming back to the subjects and coming with a deeper view. So we have seen all the surfaces before, now we are seeing the vessels and how we use the surface to get to know the vessels. So anyone who's listening to us, please notice that and stick with us, because we are going deeper and deeper in the understanding of the brain and everything that is around it. So we will be coming back to those subjects in the next talks. I think we have a comment here from a resident of yours, Dr. Bandeira. He's saying, thank you so much for your wonderful lecture. I would like you to repeat the angiographic reference to find the supramarginal gyrus, please. And in surgery, would it be possible to use the acoustic sulcus as a superficial reference point to find the limit between the polar plane and the temporal plane? You mean the rhinal sulcus, I guess. So two questions, Wen.
You know, well, thank you very much for your question. He's already master. He was resident years ago, but now I'm sure he's master already. The thing is, between the plano and temporalis, it's the most posteriorly located upper surface of the temporal lobe, and the plano polare, there's a Hash's gyrus. If you can identify, yes, definitely, it's a very good landmark to tell you where the Hash's gyrus is located. But for, usually most of MCA aneurysms, they arise either at the genu or at the proximal, M1 or distal M1. And very rarely you have a distal aneurysm of NCA, at that back, as far back as the plano-temporale, okay? And also the angiographic landmark, I don't recall, when I was young, much younger than now, I was always wondering what the hell where is this Sylvian point? Because everybody was this is Sylvian point, it should be located at the center. I was I was thinking, where is this? So now I started dissecting the brains, and I said, oh, the definition of the angiographic Sylvian point, or point M, is the most medial or most posterior, the last loop of the MCA before exiting the Sylvian fissure. So I was doing my dissection looking for the last loop. And the last loop was always on top of the most medial, most posterior part of the Hash's gyrus. And then I saw the relationship of, the point M to the atrium. And what structure is the anterior wall of the atrium? Pulvinar of the thalamus. So point M tells me not only where the Hash's gyrus ends, it will tell me where the central core ends, where the thalamus ends, where's the atrium is located. So, these are the joy of studying anatomy, because not only you don't only have to dissect. During the time I spent almost 3 years in Gainesville, I was not dissecting every day. There are days where you have no motivation, nothing, in your mind to dissect. You don't know what to dissect. What's the best way to overcome this? Go to the library. Luckily, in Gainesville, the University of Florida, the library of the university is right next to our lab. Just walk out the building. The next building is the library, and it's open until midnight. So you have no inspiration, no motivation. Go and study. Find the motivation. I will advise you the same. You're stuck in your career. You're gaining money. No, try to dissect, study. Do something good. Improve yourself. You're already a very wonderful neurosurgeon, but I'm sure you can improve a lot. You're very young. There's a long way to go. The wonderful career ahead of you.
When we do have some more questions,
Okay.
I think we can send them to you by email, and if anyone wants to put their email on the chat, Wen can get back to you by email, probably. I think we are about time to wrap it up and to finish for today. Lots of people thank you, Wen, and I do thank you as well. I think it was a great talk. Thank you very much.
I thank you all very much.
Would you like to say something to round it up?
Oh, yes. many 30 years ago, when I was about to finish my research fellowship, Dr. Rhoton stopped me, at the lab. He stopped at the lab and started talking to me. Hey, Wen, now I got more than 20,000 slides from Gainesville, from that lab. Now you have material, teaching material for the rest of your life. Don't waste it. Okay, so what I'm doing here is to keep my promise to my boss. And I hope you have wonderful, all of you have a wonderful career. And I wish I can be part of it. Okay, so I thank you all so much. Once again, thank you, Carol. Thank you, Imad.
Thank you, Wen.
Thank you so much.
So
See you
guys,
next
thank you
time.
everyone. Bye-bye. See
Thank you
you
so
next
Bye-bye.
month
Yes.
in fact, I see you next week on the meeting for the peripheral nerve. Next Friday, right? Every
Yes.
Friday is anatomy day. See you all there then. Bye-bye.
See you.
Thanks.
Bye.